On behalf of ISCH, I welcome you all to ISCH webinar series. Today's presentation is titled Frontline Therapy of CLL. Where do we stand? Will be presented by friend, colleague, and well-known CLL leader in the field, Professor Paulo Ghia. Professor Ghia is a full professor in medical oncology. He is a director of strategic research program on CLL at the Università Vita Salute San Rafael. He is also a national coordinator and principal investigator in phase 1 to 3 clinical trial in CLL. He is a president of European Research Initiative on CLL, co-chairman of the Working Party on Lymphoproliferative Disease of Italian Group of Adult Hematological Malignancy. He's also section editor of CLL at Hemisphere, which is very high impact factor, rapidly rising open access official journal of EHA. Is a co-author of ISMO guidelines on management of CLL. Let me mention here that ISCH is structuring the education through kind of pathways dedicated to given disease. And this webinar is a part of our CLL Academy initiative launched recently. And we have one of the world leader in CLL to present CLL Academy initiative presentation today. Professor Ghia, floor is yours.
Thank you very much also for the very kind introduction. I thank you because indeed I'm always happy to speak about chronic lymphocytic leukemia, which is our passion since a couple of decades, but also because this is really, we have been saying that for 10 years now, but every year we have a lot of new things, innovations, and we are really moving fast forward in the management of patients with chronic lymphocytic leukemia. So I'm very happy to give you this update. Let's say maybe in 1 year time will be completely different. As I always say to my patients, I never discuss a diagnosis, what the options of treatment will be one day, because we will not know. Things will change and will move very fast, so that within 6 months, we might find ourselves in a completely different scenario. This is a very broad picture. Sorry. Showing you that the therapies, as you know, therapies in CLL, sorry, something happened. Therapies in CLL now are really distinct between the continuous treatment with BTK inhibitors on one side, that have been the first piece of armamentarium that we had available in chronic lymphocytic leukemia. And then now we have a lot of different combinations, including the BCL2 inhibitors, venetoclax. And we will see how the field evolved and where we are standing, as the title of the seminar suggested. So I have to say that, as mentioned earlier, everything really changed probably 10 years ago with the introduction of the BTK inhibitors, in particular of ibrutinib. And now we do see the results after 10 years of a continuous treatment with BTK inhibitors, in particular ibrutinib. And so we have been able to show that patients of any age have a similar life expectancy to age-matched population. And that, I think, is a major achievement, because we knew before, in the era of chemoimmunotherapy, that our patients were dying earlier, they were dying of the disease. While instead, in our age nowadays, we can really think very positively about the outcome of our patient. Of course, we know that we are not still curing the disease, so we are controlling it very well, but still we are not curing. So the next generation of studies, the next generation of research needs to address the point of one treatment for cure. Having said that, all these results with ibrutinib were started again 10 years ago with the RESONATE-2, which has been indeed a historical study, because for the first time we needed 10 years to show a PFS, to reach the median PFS survival of a drug in chronic lymphocytic leukemia. So indeed, with ibrutinib, you can expect more than 9 years of PFS, more than 50% of the patients will remain almost 10 years in response when using ibrutinib. And that is true, has been confirmed also by the second generation BTK inhibitors, zanubrutinib and acalabrutinib, that have been developed in order to address the safety issues that came apparent with ibrutinib, so the cardiovascular toxicity. So zanubrutinib and acalabrutinib have less, are better tolerated, have less cardiovascular toxicity, but they showed exactly the same capacity in terms of efficacy, though of course the follow-up is shorter. We are between 5 and 6 years, while instead with ibrutinib here we have the longest follow-up. And here I just show you a drawing suggesting where you might use these drugs, because at the end of the day it's probably difficult based on efficacy to choose to pick among those. For ibrutinib, we have data also against FCR, fludarabine, classical fosfonamide, rituximab, so in the young fit patients. With the zanubrutinib, we have data in the Sequoia study versus bendamustine plus rituximab, so older patient but still fit to receive bendamustine plus rituximab, and acalabrutinib alone or together with obinutuzumab was tested against chlorambucil plus obinutuzumab, so in the more unfit patients, in particular elderly patients. But still, the curves look very, very similar, and so we can expect a long-term benefit from the continuous use of BTKI. And in particular, what is now common knowledge, even outside the CLL field, is that the continuous BTK inhibitors is probably the preferred choice, the preferred option for patients with the deletion 17p and or mutation in the p53 gene. And as you can see here, and the PFS, we are talking about PFS that have not been reached after 5 years, so 70% of patients with treated with acala or zanubrutinib are still responding, and here we have a little bit longer follow-up, 6 years, with the NIH study by Adrian Wiesner with ibrutinib, again 63% of the patients still responding. So very similar number, very similar confidence when you use p53, when you use BTK inhibitors in controlling patients with p53 aberrations. The thing is that now the field is evolving. So this is the, I would say, the stepping stone that we reached already a few years back, and on which we design new trials, new ideas, new approaches to chronic lymphocytic leukemia that now are at our disposal, meaning that now indeed the priority, even in our ESMO guidelines, ESMO EHA guidelines, so the guidelines that have been developed in Europe, really put fixed duration treatment as first option in the vast majority of the categories of patients, subgroup of patients. So here you look like patients with very good prognosis, mutated immunoglobulin genes, fit or unfit, unmutated immunoglobulins, fit, unfit, and still you do see that there are combinations, including venetoclax as a fixed combination. We are going to talk about those. For the patient with p53, we still remain somehow attached to the use of continuous treatment with BTKI, though even there the vision, the concept is evolving, quickly evolving. So where are we going? Not only where are we standing, but where are we going? I have to say that the same very picture, I've been changing it in the past 12 months. And at the beginning, probably 12 months ago, I wrote, where should we go? And then it became, where shall we go? And then where are we going? Meaning that we are already on the path, and the path is really towards the time-limited treatment. And the major concept that came out in these past few years is that we wanted to use fixed duration treatment, time-limited treatment, to maximize quality of life of patients. So to give short course of therapy, so no issues on long-term adverse events, no financial issues, no compliance issues, patients forgetting to take therapy. So that was the idea, to give a therapy not to cure the patient. So nobody ever planned to cure the therapy with only 1 or 1.5 year of treatment, but was really to improve the quality of life of patient, to give a maximal therapy for a short period so that the patient can enjoy a drug break, and then the disease will come back, as we know, as will come back even after continuous therapy, and then we can treat again the patient with the same therapy, so not without occurrence of resistance. So keeping the armamentarium as broad as possible. So that is the idea. Of course, to develop this idea, we need to build around a very potent drug like BCL2 inhibitors, able to give undetectable MRD status, and that was combined with obinutuzumab anti-CD20 antibody, or more recently with the BTK inhibitors. So the idea was short period of treatment to maximize quality of life. And venetoclax plus obinutuzumab, we know that it's been explored in the CLL14 study by the German CLL study group, though it was an international study. And it was venetoclax given for 1 year, obinutuzumab given for 6 months in the first 6 months, compared to chlorambucil plus obinutuzumab given for, again, exactly the same period, chlorambucil for 12 months and obinutuzumab in the first 6 months. The results were very impressive, thinking again that it was 1 year, 12 months of treatment, and everybody stopped. The progression-free survival, again, we needed more than 6 years to achieve the median progression-free survival, so more than 50% of the patients were still responding at 6 years. We started seeing differences from a biological standpoint, and that is interesting because, of course, this knowledge became also relevant to interpret the future data and also with other combinations. So on one side, when patients have p53 aberration, if they are treated with obinutuzumab plus venetoclax, they do much better than when they are treated with chlorambucil plus obinutuzumab, but still they relapse earlier compared to those who do not have p53 aberration. And that already led, since the beginning, to the idea that probably I would prefer to use a BTK inhibitor, because here it seems that you are losing control even quite early in some patients with p53 aberration. Looking at patients stratified based on immunoglobulin gene status, we do see that patients with mutated immunoglobulin genes have a very long, not reaching a plateau, but a very long PFS when they have mutated immunoglobulin genes. Those who have unmutated immunoglobulin genes, they do progress earlier. Later than patients with p53 aberration, but still earlier than patients with mutated immunoglobulin. Still, in patients with immunoglobulin, unmutated immunoglobulin genes, we have 64 months of median progression-free survival. So more than 5 years, 5.5 years, with only 1 year of treatment, no occurrence of resistance, possibility of utilizing again the same combination, or based on the reimbursement policy, venetoclax plus rituximab, for example. Then we wanted to develop further the idea of the combination of short-term treatment, and therefore, together with Konstantin Tam and Bill Virda, we designed the CAPTIVATE study. It is the first study that combined ibrutinib, so the BTK inhibitor at that time, the only one that we had, plus venetoclax. And we also explored an MRD-driven approach, but at the end of the day, what became important and was approved was the fixed duration treatment. Anyhow, the treatment included 3 cycles, 3 months of ibrutinib as a lead-in to debulk the patient, and then 12 months of the combination ibrutinib plus venetoclax, and then everybody stopped at the end. Actually, we designed the fixed duration arm after starting enrolling on the MRD arm, because we really realized that we were very good in leading patients into undetectable MRD. So roughly 3/4 of the patient could reach undetectable MRD as best response. And therefore, we felt confident that we could use also a fixed duration approach in our patients. So these are the results, 7 years of follow-up. PFS, as you can see, is not being reached, even if we are using therapies only for a little bit more than 1 year. So this is, again, comparing, I would say, very favorably when we think about continuous treatment with ibrutinib, of course, there we needed 10 years to achieve median progression-free survival. Here we probably need a little bit less, but still 2/3 of the patient after 7 years, up to 7 years, so with a median of 5.5, were still responding. Of course, the overall survival is impressive, and it is 97%, meaning that we can really rescue the patient. And we have shown that, in fact, these patients, when they progress, they can be treated effectively with either ibrutinib alone or ibrutinib plus venetoclax, again, for a fixed duration treatment. Unfortunately, this combination in the retreatment setting is not reimbursed, neither approved in any country in the world. Again, we went a little bit into the biology, and when we look immediately to the patient with 17p or mutated p53. And again, also here, we do see that these patients have a poorer outcome, so they progress much earlier than all the other patients without such aberration. But still, those with roughly 1/3 of patients will be free of disease, of recurrence, after 5.5 years. When we look at the patient without p53 aberrations, then we also do see a difference between patients with mutated and patients with unmutated immunoglobulin genes. But here the picture seems a little bit more favorable, meaning that if we look at the unmutated patient here, and then unmutated patient in the fixed duration cohort, more than 50% of the patients are still responding after 5.5 years. So the famous 65 months that we saw in the CLL14. Of course, we cannot compare the studies, but it looks like it's promising in this sense. When we look at MRD, so that was the important point that we learned from this study, and we look again to the patient with deletion 17p and p53 aberrations, then we do see a dramatic difference if the patient achieve undetectable MRD here. And the interesting point that almost 50% of the patients are still in response after 5.5 years, despite having deletion 17p and p53 mutation, if they achieve undetectable MRD. Of course, if you look at patients who don't achieve undetectable MRD, they already progressed. They all progressed after 5 years. So this may open a new path for the future research, which is probably to optimize therapy in this particular category of patients. We have to start relying and studying the level of undetectable MRD. Here I also show you time to next treatment, which is very impressive. So not only the PFS, the disease, when it progresses, it seems to progress not in an aggressive fashion, in a rapid fashion. So the time to next treatment is here. 73% of the patients, so 3/4 of the patients, don't need a treatment after 5.5 years, which is, again, very, very reassuring, thinking that patients have been treated with less than 1 year, and you have still all your options there that you can use in your patient. Again, if you look at the fixed duration cohort only with 69%. So definitely more than 2/3 of our patients. The same combination has been tested also in the GLOW study, so elderly patient or comorbid patient, ibrutinib plus venetoclax 15 months compared to chlorambucil plus obinutuzumab, because these were unfit elderly patients. And the results were very similar, so of course it was better than, the combination was better than chlorambucil plus obinutuzumab, and you do see that here you have 2/3 of the patient still responding after more than 5 years. The interesting point again is that patient with achieving undetectable MRD have a better outcome compared to those who do not achieve undetectable MRD, with the exception of patients with mutated immunoglobulin genes, where indeed the difference is now becoming apparent, but very late. So very likely in patients with mutated immunoglobulin genes, the response can be very nice and very prolonged, regardless really the undetectable MRD status. Or I would say that the undetectable MRD status will have a value only after many, many years, and especially for the elderly unfit patient, maybe they will not live long enough to see that point. The time to next treatment is also very impressive here, as you can see. So again, very similar number is 5.5 years as well, and it's again more than 2/3 of the patient still not needing treatment. So the same study that we did for ibrutinib monotherapy, we did it also for ibrutinib plus venetoclax, and even if the follow-up is shorter here, we were able to show that any patient more than 65, less than 65, with unmutated immunoglobulin genes or with mutated immunoglobulin genes, still you don't see difference between the expected life of age-matched population and the survival of the patient enrolled in this study. The interesting point that I always like to show is that in the patient with mutated immunoglobulin genes, we do even see a better outcome for patients who have been treated with ibrutinib plus venetoclax compared to age-matched population for a number of reasons, including the fact that the patients have less issues from the disease because it's a more indolent disease. But of course, by the continuous monitoring, the continuous follow-up, the continuous visits, patients are better followed. So probably they vaccinate more, probably they do the cancer screening, probably we find earlier cancer or cardiovascular issues. So because we monitor them, because they did ibrutinib. So at the end of the day, these patients are better followed, and therefore we could expect indeed an improvement in their life expectancy. The combination of ibrutinib plus venetoclax did not increase toxicity, as one might have feared, with only the exception of diarrhea, that is a side effect of both ibrutinib alone and venetoclax alone, and putting together is 2/3 of patients have diarrhea, which are most, if not all, grade 1 and 2, and typically, as always, not like dialysis, it disappears within a few days, a couple of weeks. The other issue is neutropenia, that is exactly what you would see in the use of venetoclax monotherapy. So 1/3 of patients having grade 3/4 neutropenia, but that did not translate into infections when we look young patients enrolled in the Captivate, 70 years or below. When we look at the GLOW study, so patients with 65 years or more, then the situation is a little bit is a little bit different, but as you would expect in the elderly population, we have always to remember that we are treating elderly patients. We have to be careful with the elderly patients, and therefore we have to keep an eye, a closer eye. So we do have neutropenia in similar range, but the double in terms of infections. Then we do have atrial fibrillation, hypertension, and so on. A few patients also died of cardiac comorbidities. So we have always remembered that when we use a BTKI, we have to do a thorough cardiovascular workup, not in order to exclude anyone from the therapy, but in order to fix whatever can be fixed. So to find an hypertension that was undiagnosed, to diagnose a diabetes, an ongoing diabetes, to see any issue, valvular issue, or anything that can be fixed prior to start the therapy. Of course, since ASH, we have now another combination, which is acalabrutinib, so second generation BTK inhibitor plus venetoclax, that was compared to acalabrutinib plus venetoclax plus obinutuzumab, the anti-CD20 antibody, so the triplet, which is somehow thought to be the next frontier, and then compared to SCR, fludarabine, cyclophosphamide, rituximab, and bendamustine plus rituximab, so fit patient, both young and elderly. And we published this together with Jennifer Brown and many other colleagues. And the treatment again is 14 months here, only 2 months of acalabrutinib followed by 12 months of the combination. And as you can see here, the results, we have 3/4 of the patients still responding with AV, acalabrutinib venetoclax, at 3 years, more with when you use the triplet. And this is for patients with unmutated immunoglobulin genes, which are the one that we care the most. And we do see that, again, the triplet is better than the doublet. Maybe the doublet seems a little bit less effective than VO or IV. The triplet is similar, if not superior. This is the overall survival. There is an advantage for patients treated with acalabrutinib plus venetoclax. The fact that AVO was not superior to FCR-BR was mainly or only due to the COVID-19 deaths that occur more in the AVO arm, as you can see here, similar to FCR-BR. So if you censor the COVID-19 death, then you do see also an advantage in AVO. That to remind all of us that when there is obinutuzumab around, an antibody, there is always a higher risk of infections, and in particular of lethal infections as well. So we have always to be careful and select well the patient where we plan to use obinutuzumab, in particular in the context of a triplet. But all that considered, in particular in a period where COVID-19 is not clinically relevant anymore, fortunately, then we could consider a patient for the use of AVO, of the triplet. In terms of adverse events, we do see little cardiac events and atrial fibrillation, as we would expect with the use of acalabrutinib, but also for the short period of treatment. In terms of neutropenia and particular infection, grade 3 infection, then you do see that AVO, the triplet, is what is more concerning. So we have really to pay attention and to screen well the patient before starting a triplet. But the issue of the triplet has been already shown also for IVO, ibrutinib, venetoclax, obinutuzumab, where in the Gaia CLL13 study, where young patients who were treated with venetoclax-based therapy, so not only the triplet, but also venetoclax plus cetuximab and venetoclax plus obinutuzumab compared to chemoimmunotherapy. And as you can see here, there are more cardiac events, but in particular more infections here that are apparently in the range of patients treated with chemoimmunotherapy. So we have always to consider that. So where should we go? Now I changed again the title of the slide. Where should we go? We are very happy with the continuous BTKI. We are even happier with the fixed duration treatment. So many advantages, including a financial advantage. We would like to go for cure. And what we have to do, we have to think about the treatment. It is one lifetime treatment. Once for all, your treatment is done. And of course, here you have to introduce MRD-guided approaches, and in particular, you have to go as long as it takes. Of course, you have to be prepared in that sense. And that is this has been explored by Pete Hillman and all the colleagues at Al Munir and all the colleagues in the UK with the FLAIR study. Again, the combination of ibrutinib plus venetoclax that was given in a very MRD-driven way, meaning that patients were treated for a period that was double than the period they needed to get to the undetectable MRD state. So if a patient needed 1 year, the patient was treated for an extra year. If they needed 2 years, they were treated for an extra 2 years. If they needed 3 years, they were treated for an extra 3 years, for a maximum of 6 years, and then stop. With the idea that the longer you go, the more patients you cure until you get to 100%. This is not really the case. What we learn also a lot from this study is that you can get to undetectable MRD within 2 years in 50% of the patient, 2/3 within 3 years, and 3/4 within 4 years. Interestingly, there were differences between unmutated and mutated patients, and counterintuitively, they were able to reach undetectable MRD much quicker and in much higher proportion in patients with unmutated immunoglobulin. So at 4 years, 80%, so 4 out of 5 patients, more than that, achieved undetectable MRD against the 60% of patients with mutated immunoglobulin. But probably here we don't care. So that's what we learned. That probably we don't need to go for so long. So these are the patients, the 40% remaining are the patients who are still on therapy for 5 or 6 years, and they definitely don't need it because we already learned from the other studies the patient with mutated immunoglobulins can be controlled, the disease can be controlled easily with only one or 12 months or 15 months of treatment. But what we also learned then is that the patients with unmutated immunoglobulins are those that are more prone to get into undetected MRD. And the results that were presented at the EHA Congress are impressive because for the first time, they show that a fixed duration treatment was superior to continuous ibrutinib. And that is the result. So I plus V here, ibrutinib and FCR. And this is the PFS, which is expected somehow, but in terms also of progression-free survival, and that is really impressive with numbers that are approaching 100%. If you remember, now here, this is 5 years, even with ibrutinib plus venetoclax only 15 months, at 5.5 years, we had 96%. So in terms of overall survival, we have still to understand if it is worth it to, beside the actual efficacy, the actual clinical efficacy, how an MRD-driven would be worth it compared to a time-limited treatment. For the simple reason that it is, of course, much more cumbersome. You have to test for MRD, you have to interpret MRD, and so on and so forth. And then you get the chance to be treated for 3 years instead of 2 or 1. I just want to give you an idea of how things can evolve, because what we learned from FLAIR is that definitely nowadays, if one should design again the same study, would not go anymore to 6 years, because we learned that not everyone will get into undetectable MRD, even if you treat them for 6 years, and probably not even if you treat them for 10 years. So if you are selecting a subgroup of patients who probably don't benefit from this combination only, and those are the ones that should be treated with something else, with something different, with something more. And that's a principle that we started developing in a relapsed refractory setting with an improved study, a phase 2 study, where patients were treated first with ibrutinib for 1 year. Those who were becoming undetectable MRD stopped treatment, and there were those who did not become undetectable MRD, they added the ibrutinib, so 2 drugs, and for an extra year, those who were achieving undetectable MRD, they were stopping. And those who did not achieve undetectable MRD after 2 years, one could say you could have added the obinutuzumab. We didn't do that. We just continued the ibrutinib continuous treatment, because we thought we identified the difficult to treat patient, and therefore they were the one that for sure we could control well with a continuous BTK inhibitor. And as you can see here, summarized, almost 50% of the patient needed 1 drug. Almost another 50% of the patient needed 2 drugs to achieve undetectable MRD. And then only 10%, which was 3 patients, needed to continue ibrutinib. So we didn't waste drug in any patient. We used as much as it was necessary, not more than that. And I think this is the approach that we should develop for the future, to personalize really the quantity and the length of the treatment for each single patient, not starting from a single 2 drugs, but maybe only even with a single drug. This is the PFS 40 months, so more than 80% in 40 months. We are in the relapsed refractory setting. The field is evolving, as I mentioned. Now we have the third generation BTK inhibitor, pirtobrutinib, that was tested very recently in a preliminary study, in a phase 2 study by Dr. Jain and Bill Virda at MD Anderson. Pirtobrutinib, third generation BTK inhibitor, venetoclax and obinutuzumab. You can see here impressive numbers. 90%, 98%, 100% of patients achieving undetectable MRD at the end of the 13 cycles of treatment. And just for the fun of it, as a colleague said, here I show you the PFS, which is like a horizontal line, because of course the follow-up is very short, it's not even 2 years. But just to tell you that things can improve and will be improving. And with that, I'm going to conclude. For those who are interested, we will know at ASH this year the comparison between ibrutinib continuous treatment and fixed duration treatment, time limited treatment, venetoclax plus obinutuzumab or ibrutinib plus venetoclax. So please follow the data and you will see, you can start betting. And I just want to conclude reminding everyone that nowadays we go for a more personalized approach. There is not a therapy that is the best that should be given to everyone. We should really take into consideration many different aspects, definitely the biology of the disease, mutated immunoglobulin genes, P53 aberration, definitely the patient profile, also the age, the comorbidities, in particular cardiovascular comorbidities, the drug profile, and what happens when you combine two drugs, but also the patient preference becomes relevant, because really when I approach my patient, I tell them, look, we are not going to make any wrong decision. Whatever we take, we have just really to understand what fits better your life, your schedule even. And for that reason, I'm happy, I like to show this table, which will be somehow used in the new EHA guidelines that will be developed and released by the end of the year, where there is not a single drug or a single combination that is perfect for one category or subgroup of patients, but it's really a nuance of all the an evaluation of all the different nuances, of the different grades, I would say. So one has to keep into consideration all these different factors, biological factors, treatment-related logistics, adverse events, comorbidities, and then find a balance, a compromise, what can be best for the patient that you have in front of you. And with that, I conclude, and I can give you my opinion how I would treat the patient, or maybe we can discuss later through the questions. And I want to thank everyone who worked with me so far, both in Milano and in Boston here, and also my long-standing collaborators in Greece. Thank you very much for your attention.
Professor Ghia, thank you very much for your top class CLL Academy presentation today. As expected, we have received numerous positive comments and several thoughtful questions. Unfortunately, we don't have enough time to address each individual question, okay, but I'll do my best to summarize and incorporate a few key ones for you. First question, it's on if unmutated immunoglobulin heavy chain variable CLL get more rapidly to MRD negativity, but has a worse PFS and OS than mutated CLL. Does that not make the use of MRD as an endpoint in CLL studies misleading?
No, absolutely. It's absolutely a great point. In fact, what we learn is that undetected patients with unmutated immunoglobulin genes go into undetected MRD much more quickly, but they also relapse quicker than mutated patients. But then we have to forget the mutated patients. We have to consider among unmutated patients. Among unmutated patients, those who achieve undetected MRD, they progress much later than those who do not achieve undetected MRD. So it remains an endpoint for studies, because it tells us, it identifies the patient who will benefit the most in the long run. We are not curing, so if you are telling me that it's not an endpoint for cure, maybe not yet, maybe not that level that we are detecting now. Yes, patients are not cured. We are not promising cure at the moment. We are really promising probably only a longer PFS than before.
So next question is on the line of MRD also. Timing of MRD measurement in TP53 treatment with BTK inhibitors.
With BTK inhibitor alone, you don't really need it. It's difficult to achieve complete response. Definitely much rarer to achieve undetected MRD. I'm not even aware if anyone ever reached that. So there is really no need. For the combination that now we are indeed all exploring, it is not contraindicated to use time-limited treatment in patients with deletion 17p or p53 mutation. And there, maybe you want to follow the patient every 3 months during the treatment to see how it goes, and then maybe every 6 months.
So next question about your personal opinion. First line, time duration therapy, your choice combination?
Oh, in Italy, in Europe, we have now a lot of experience with ibrutinib plus venetoclax. That remains, it is become safe because it's only 15 months, so you don't have the problem of long-term toxicity. It's very effective, and at the moment, the PFS, the median PFS with a longer follow-up, of course, looks very, very robust. So it will be nice to see how the other combination will do with 5, 6, 7 years of follow-up. At the moment, again, there is no, I know that in the US, for example, there is not much use of ibrutinib. I plus V is not approved, but in Europe and the rest of the world, we are really using it a lot, and we are, I would say, happy, and patients are happy. And so that is my first choice. Also for logistical reason compared to venetoclax plus obinutuzumab, because it's all oral, and in particular, you start with a BTK inhibitor that gives you immediate control of the disease. So even if you have large lymph nodes or the patient is aggravating, then you know that in few days, a couple of weeks, you get control. So you don't need to do the ramp up. And then when you get to the combination with venetoclax, every single physician, every single patient will be very relaxed because the disease is virtually gone. So that is also a very important point.
So this is last one is, let's instigating question about transplantation.
Oh la la.
In your opinion, any indication of allotransplant after first-line therapy?
Yes, it's a very good question. It is indeed, according also to some recommendation that we wrote a few years back, the idea was that you have to start contemplating and discussing the allotransplant after you fail the first therapy, the first targeted therapy, so that you can use the second one to get to a good response. I would say definitely nowadays that I would consider allo in a young patient who relapses after 2-3 years on ibrutinib, for example, on acalabrutinib, on a BTK inhibitor, because that patient is bound to do poorly. Because even if you use venetoclax, it will probably last a couple of years. And then you have pirto, probably another couple of years. But if he's young, we will not make it to anywhere. So that is probably the only context where I would be really, really seriously speaking about it.
Thank you again, Professor Ghia, for your excellent presentation and disseminating knowledge to our patient. I wanted to thank all our live audience also for joining the webinar, and for those not able to join, full recording of webinar will be available on ISCH website. This is in line with our mission of Hematology Without Borders, and anyone can view all past recording anywhere in the world, anytime. Professor, thank you so much again.
Thank you all.